Dr. Jason is a professor of psychology at DePaul University and the director of the Center for Community Research. He is a former president of the Division of Community Psychology. In 2011, he was presented with the Tom Fellows Award by the Oxford House Organization for his 20 years of research documenting the process of long-term recovery from addiction. He's extremely accomplished. Dr. Jason, as many of you know, he's written 23 books, many of which are at our bookstore on our scraw display table. There's some additional things, and what I just said, and there's some additional things you could read about in the conference program. What you might not read about in the official bio are some pieces of information that I found on Wikipedia. So when you have a Wikipedia page, to me that is like the pinnacle of success, okay? That and being quoted in Jet magazine. So as an academic, even though I tell my students that they can't rely on Wikipedia, I found it interesting that on Wikipedia, Dr. Jason can tell us if this is true, he is actually the son of Jay Jason, a well-known comedian who apparently entertained in the Catskill Mountains. I don't know if that's true or not. Anyway, I'll be quiet now. I want to have you help me welcome Dr. Jason to the stage, and after his talk I'll give a couple of announcements about the conference. But please join me in welcoming our distinguished keynote speaker.
Yeah, my dad was a comedian, but don't trust what you read on Wikipedia. Talk today is going to be on principles of social change. The starting point in the social change process is that change begins, as Ferrari said, by helping people identify issues for which they have strong feelings. And from my point of view, social change is more likely when we have a passionate interest in the particular issue or problem we're dealing with. I've always felt that intuition is really a guide in any type of social change. It's the beginning point. It's the recognition that something is wrong and unfair. The feeling is clear something needs to change. Intuition can steer us in the right direction toward second-order change. During this talk, I'm going to talk about 5 principles, and these are things that have guided some of the work that I've been involved in over the years. They involve structural second-order change, confronting power abuses, mobilizing coalitions to deal with those power abuses, and to hopefully gain that second-order change. Having a long-term time perspective so that one can work with those coalitions, and using feedback to fine-tune the work. What I'm going to do today is provide concrete examples to illustrate efforts toward different types of things involving agenda setting, policy formulation, policy implementation, and policy evaluation and revision, as Ken Mappin said in an earlier session before this. Certainly the communications and relationship skills are critical for community psychologists as we work on these particular issues, and some of those will come through and put the important issues of doing those things. The first principle of social change is determining the nature of the change, and as we all know, we don't want to be involved in cosmetic short-term fixes. We want to address the root of the problem. First-order change attempts to eliminate deficits and problems as we know. It promises to solve the most deeply rooted problems with simple solutions. It provides at best short-term solutions and, unfortunately, renders people powerless to overcome their oppression. As we all know, second-order change influences the individual and his or her social networks. It alters shared goals, roles, and power relationships. An example of second-order change I'd like to provide involves the issue of car restraints and safety seats for youth. Each year, thousands of children are either injured or killed in car accidents. It's due to them not being placed in appropriate infant and car seats. In the 1980s, the actual leading cause of death for children under 1 year of age was car accidents, and that was because infants were not in appropriate infant seats. In the 1980s, a national coalition came together, and Steve Fawcett was one of the people who put that together to influence legislation across the United States. I was involved in an effort in Illinois working with the Child Passenger Safety Association, and this was a community-based organization trying to get child restraint legislation. In a nutshell, the proposed Illinois restraint law that we worked on had 2 main purposes. One, children under the age of 4 needed to be required to be placed in an appropriate child or infant car seat. And two, children aged 4 to 6 needed to be in either an approved restraint system or a secure seatbelt. The question that we asked ourselves is, could we actually influence legislators to vote for this bill that we felt was really important from a public health point of view? Our research team collected behavioral data by looking inside cars to see whether or not infants and children were placed in car restraints. We also collected telephone surveys regarding citizen attitudes toward the proposed child restraint bill. In collaboration with the Illinois organization, we sent critical information to a random half of the state senators. We wanted to assess whether our targeted letter had made a difference in voting for the bill. The letter was received by the senators 1 week before their vote. The information was clear and concise. It increased our chances that the letter would be both read and remembered. The content of the letter involved these pieces of information. 140 children in Illinois were killed and over 25,000 injured in automobile accidents over the prior 6 years. In our data, we found that 93% of Illinois children were not in adequate restraints while riding in cars. We also found that 78% of adults supported the child restraint passenger bill. 79% of the senators who received this one-page letter voted for the passage of the bill. 53% of the senators who did not receive the letter voted for the bill. We were able to significantly influence the voting for this bill. The governor, when he found out also about our work, requested a copy of our findings before signing the legislation. These are some of the outcomes of this legislation that are immediate. For children between the ages of 1 and 4, as you can see, car restraint was about 13%. After the legislation, with this little arrow, it went up to 42%, a couple months right after the passage. For infants less than 1 year of age, appropriate restraints increased from 49 to actually 74%. What about long-term outcomes? Comparing deaths 2 years before to the period 2 years after the law, child deaths decreased by traffic accidents. And you can see at 53% from 49 before to 23 after as a function of this law. These were some comments from the Illinois Child Passenger Safety Association members regarding the work that we did with them. The data were helpful and important and of high priority to have as part of the armamentarium. The data were very, very interesting. It was a building block in the passage of the bill. Those who had the data and understood them, it made them more forceful and vocal in support of the bill. We believe this is an example of second-order change. We worked collaboratively with a community-based organization. Our data was influential in terms of helping legislative officials support the law that contributed to real change. In this case, protecting the safety of infants and children when driving in automobiles. So, principle 1, focus on second-order change. It's only through more structural interventions will we make a significant difference in solving our social problems. In this case, legislative change to protect our children. Second-order interventions direct precious resources in more productive ways. And as we all know, they go beyond reactive responses by enacting measures to avoid potential problems. The second principle of social change involves identifying the power holders. Creating second-order change can seem overwhelming for the work that most of us are involved in. Powerful people or organizations control whether change will be enacted. Social inequalities are caused by an underlying abuse of power. Redistributing power is often a crucial component in second-order social movements. The causes of abuse and underlying power structure are often difficult to see clearly. We need to focus and appreciate that instincts. These we can use as powerful tools to uncover the veiled power abuses. We must use the same passion and intuition that helps one see the path towards effective second-order change. This is so we can identify and analyze the distribution of power. So let's talk about another example of using the second principle, and the one that I've had some experience with, but again, we could probably use many experiences from people in this audience, involves tobacco, which kills over 400,000 people every year. it's the most preventable cause of premature death and disease. The tobacco industry is responsible for enticing many young people to begin smoking. Every day, 3,000 American adolescents become established smokers. Of these, 1,000 will die of tobacco-related illnesses. The tobacco industry has multiple efforts to widely distribute cigarettes to youth. So the question is, how do we fight this industry with many more resources than certainly we have? Well, in the 1980s, I was involved at DePaul University in launching some school-based smoking prevention programs. Students told us while we were implementing these prevention programs that merchants in the community were openly selling them cigarettes. That contradicted our prevention message, so we felt we had to take a next step and not just focus on the individual person-centered individuals in our classrooms, but also the merchants in the community. The question is how to stop that tobacco industry. Person-oriented approaches are compromised by social and environmental factors, such as merchants selling tobacco to youth. The tobacco industry had power to influence any laws that could affect sales of tobacco to youth. We first started with an exploratory study. Our intuition pushed us to explore the students' critical input. We wanted to assess illegal merchant sales of tobacco, so we sent youth into stores to purchase tobacco. We found over 80% of merchants sold tobacco to minors. This is a piece on the news.
You know, it's hard to make a decision about smoking and when and where and under what particular conditions. The easier thing, of course, would be to never begin smoking in the first place. And on that subject, there is some news to report tonight. A new study that has been done on children and how it is that they begin smoking, which they do in large numbers every year. Thousands of children between the ages of 16 and 11. The authors of the study are from the Chicago Lung Association and DePaul University. They recruited some children from around the city of Chicago to help. There was Christy, who is 15, and Rob, who is 14. They went out to buy cigarettes. Eileen, she's 14, and Elena and Stephen, who are both just 11 years old. They went around their neighborhoods, all different neighborhoods, to see who would sell cigarettes to children, like this Dominic's on the north side. Sold cigarettes to an 11-year-old without even asking her age. The children visited 76 different sites. 63 of them sold cigarettes, including drugstores like this Walgreens on the south side, and an Amoco station, also south at 95th and King. 7 gas stations, all of the major chains, and all 7 sold cigarettes to children between 16 and 11. The Lung Association and DePaul, Dr. Leonard Jason of DePaul, collected the cigarettes as evidence of the study, which will soon officially be made public. Good for them, and good for the city council.
Look a little younger than didn't they? Well, after that broadcast, a police officer, a dare officer in the town of Woodridge called me up and said, you know, Dr. Jason, I've solved this problem. And I said, how'd you solve the problem? He said, well, we had the chief of police send a letter to all the merchants telling them that you're not supposed to sell tobacco to minors. So I said, well, you know, no disrespect, Officer Talbot, but that might not work, but if you want to check it out, I'm happy to kind of work with you to see actually how many merchants do sell minors illegal tobacco. So we began collaborating, and very soon after sending minors into stores to sell, to purchase tobacco, we found some very startling statistics that over 70% of the merchants in Woodridge, which is outside of Chicago, sold illegally tobacco to youth. We collaborated then on designing an intervention. The first time merchants would be required to purchase a license to sell cigarettes. Minors were sent to purchase tobacco and police would be in the parking lot. Merchants would be fined up to $500 or a one-day license suspense for selling to minors. And minors caught smoking, they would get a $25 parking style ticket and parents would be notified. This is what the data looked like when we basically, this is during baseline. You can see about over 70% were selling. This is when we did the intervention. It went down to 35 and 36%. It was really interesting. At this point, Officer Buzz Talbot called me up and he said, well, you know, we solved the problem. We got about half the people selling. And I said, well, you know, if you stop doing interventions and sending minors into the stores, it probably is going to go up. So they continued sending minors in every 3 or 4 months. And as you can see, the numbers dropped. In 1990, they were 3%, and they've been doing this intervention for the last 20 years, and they now have no merchants in Woodridge selling minors tobacco. 2 years after implementing this two-pronged program, rates of merchant cigarette sales to minors decreased from an average of a little bit over 70% to less than 5%, and again into the future it's even going down more than that. Adolescent smoking decreased over 50% in a Woodridge junior high school as well. This particular police officer that I worked with, Buzz Talbot, became a national figure in this issue of youth tobacco and illegal sales. Using Woodridge as a model, Officer Talbot helped with the passage of what's called the Sinar Amendment. The Sinar Amendment requires states to reduce illegal sales of tobacco, and often the states are now using the exact same methods that Woodridge implemented in the late 1980s. This particular work got lots of publicity in the New York Times, and in addition, because of this work in Woodridge, I was invited to testify in Congress during the tobacco settlement, and I talked at the legislative hearings about reducing youth access to tobacco and also increasing the cost of cigarettes. Look a little bit younger there too, don't I? Joe DeFranza, a physician, a couple years ago, did an analysis looking at laws prohibiting sales of cigarettes to minors, really that generated from Woodridge, which was the first time that community has showed that you can actually reduce illegal merchant sales. And that those types of laws and stepped up enforcement, he studied between the period of 1997 and 2003. He basically projected that these laws restricting youth access to tobacco led to a 20.8% drop in the odds of a 10th grader becoming daily smokers. In this case, research did make a difference. There's now a consensus that sales to minors should be prevented, and it's illustrated by the Framework Convention on Tobacco Control, which unanimously was adopted by the World Health Assembly, and it attracted more than 172 member states representing 90% of the world's population. Really, there's a paradigm shift has occurred in the last 20, 25 years. Rather than focusing on the youth, we now focus on the youth and the environment. Initially, over 70% of merchants sold minors tobacco illegally, not just in Woodridge, but all over the United States. Today, the vast majority of merchants do not sell minors tobacco. And the passage of the federal amendment led to states curtailing illegal sales of tobacco to youth. I believe this is another example of second-order change, and it addressed power structures. The tobacco industry, where formidable resources were used to manipulate American youth and provide them easy access to tobacco. Power holders like the tobacco industry had to be challenged by coalitions. I might add that when my study originally came out in Woodridge, the tobacco industry concluded and publicized that all you need to do is educational approaches rather than enforcements to change the problem. So they took my study and completely distorted it, but that was what the tobacco industry has done then, and unfortunately continue to do so. Community psychologists can play an important role in this advocacy effort. The third principle of social change really involves focused and collective efforts can lead to these types of broad second-order change. That involves identifying and mobilizing individuals and community groups to influence the cultural and political landscape affecting social change. The key to this third principle is community coalitions can change power structures that perpetuate first-order institutional ways of treating people. I have a little video that I'd like to show, and I'd like to thank Sarah Callahan and Madison Sundquist for putting it together. We work with over 500 ex-offenders recently, and because of that, we have a little focus of ex-offenders in this. Community coalitions can change power structures that perpetuate institutional ways of treating people. As an example, we release over 600,000 prisoners each year back to the community, and many have substance use disorders. Upon release, they face desperate living situations and their untreated addictions. This is not acceptable in a civilized society. Grassroots movements can help people in recovery integrate back into safe and supportive communities with low-cost housing options. Providing housing and job support is critical in helping them regain the skills and foundation needed to lead productive lives. In the U.S. population, alcohol and substance use disorders affect approximately 22 million people, or 9% of our population. For many with substance use disorders, treatment begins in a detoxification program. A time-limited therapeutic program will typically follow. However, these programs are becoming briefer as funding has decreased. For many people with addictions, detoxification does not lead to sustained recovery. Instead, these individuals repeatedly cycle through service delivery systems. The missing element for many patients is a supportive, cohesive setting following treatment for substance use disorders. Oxford House is the largest network of recovery homes in the country, serving over 10,000 people. They provide affordable and safe housing for people recovering from substance use disorders. This self-help organization has grown over the last 3 decades from one Oxford House to over 1,500 today. Residences are rented, single-family homes for 6 to 12 people. They are completely self-governed with no professional staff. In 1991, I saw Paul Malloy on CBS's 60 Minutes talking about this unique creation.
Would you be shocked to learn that a bunch of recovering alcoholics and addicts would like to rent the house next door to you? Well, the man who'd like to make that happen is Paul Malloy. Why does he want to put those people next door to you? And who is he anyway?
Let me read a description of these that I read. Former drinker of 2 fists of Canadian Club a day, former wife beater, former mental patient, former street drunk. True?
Yes. All of those things occurred, before I finally stopped drinking.
Malloy's wife divorced him, and he ended up on the street. Finally, in an effort to get help, he went into treatment, and then checked into a halfway house, only to find out the house was about to shut down. He and the other residents, afraid they might relapse without the house, decided to rent it themselves. Then they did something unheard of. They decided to run it themselves. No staff, no paid counselors. It was called Oxford House. It was such a success that Malloy and his friends opened another house, and then another and another. 15 years later, there are more than 200 around the country, and over 6,000 people have lived in them. Malloy heads up the central office, but the homes themselves are run by the residents, all of them former drunks and addicts, like these men in Bethlehem, Pennsylvania. What Oxford House gives them, they say, is time.
We said that once you got into this house, you could live there the rest of your life if you didn't drink, didn't use drugs, and paid your weekly share of expenses.
Those were the 3 key rules.
Those were the 3 key rules.
The average stay in each of the 200 Oxford houses is 15 months. While there, most of the residents go to almost daily support group meetings like Alcoholics Anonymous. And everyone must hold down a job to pay his share of the rent, utilities, and food. Since each house is self-supporting, everyone pitches in, which is something new for these men. Doing your chores is an essential part of recovery. In a women's Oxford House in Washington, D.C., the house coordinator makes sure that everyone pulls her own weight.
Oh my goodness, look at this. See who just washed? I'm gonna hold on to this one as you so cop to. Whoever dried clothes last, the filter was filthy. And what I want to ask now, does the person who did not clean the dryer want to cop to it? Next time, there will be a fine initiated of $50. So
$50 fine for leaving some linen.
our fines are $50, and I just got one. What, ma'am? I said everybody.
You're the one who's supposed to be making sure all the chores are done, and you got a fine?
I got a fine. I was not responsible for taking out my trash. The coordinator is the most feared person in Oxford House.
Why is that the most feared person? Because they can...
They're the ones looking at your real behavior. A lot of times you can relapse way before you pick up the drink or the drug, and a lot of people can see the behavior.
Malloy says not only doing chores, but holding an elected office helps to make a person responsible.
I think that this is where we stumbled into a very good system in Oxford House. It's democratically run. Some of the individuals in the House are elected to the President, Secretary, Treasurer, and that's important because it says this peer group has enough faith in me to believe I can take the minutes of this meeting. Or, even more importantly, they believe I can be trusted with the money and run the House checking account.
My intuition was that I should call him, although I'd never done anything like this before. I called Paul and said I was a community psychologist and wondered if anyone had done any evaluations of Oxford houses, and said I would be willing to work with them. Out of the initial conversation grew a long-term collaborative partnership between a university-based research team and a grassroots community-based organization. Oxford House representatives and my research team spent the year getting to know each other. Oxford House members helped us fashion and adapt our interview questions. With the support of Paul Malloy, we recruited 150 people who were finishing addiction treatment at an alcohol and other drug use treatment facility in Illinois. Half the participants were assigned to live in an Oxford House, and the other half received standard traditional aftercare services. We interviewed each participant every 6 months over 2 years. We found that participants assigned to a communal living Oxford House had less substance use. 69% of those who had lived in an Oxford House were abstinent 2 years later, in contrast to 35% who were in traditional aftercare. We also found that those in the Oxford House were less likely to commit a crime. Only 3% of those in the Oxford Houses were incarcerated versus 9% in the usual aftercare. Finally, we found that the 2-year follow-up, those living in an Oxford House had higher incomes than those in the traditional aftercare. Monthly incomes for those in the Oxford House were $989 versus $440 for those in the usual aftercare. These findings suggest that there are significant public policy benefits for these types of lower-cost, non-medical, community-based care options for individuals with alcohol and other drug problems. These findings were subsequently used to influence both judicial decisions as well as state-level policies. So how can we expand these types of effective programs in the community? One way was to implement an intervention involving a $4,000 loan program and a recruiter to open up new houses. To explore this, we used a multiple baseline design to chart the expansion of Oxford houses in different states. The horizontal line indicates years, and the vertical line refers to number of houses. Very few Oxford houses were established during the years before the start of the intervention. We then introduced an intervention, as indicated by the vertical dotted line at the top of the figure, in one group of states, and a few years later introduced the same intervention in a second group of states, indicated by the vertical dotted line at the bottom of the figure. As states instituted the intervention, the number of houses expanded considerably. First, I want to thank Brad Olson for running that randomized study. Certainly appreciate all the work he did over the years with that. One of the most interesting things about that study was the issue of randomization. Actually, I was not thinking that a randomized study could be done with a self-help organization like Oxford House. The reason I didn't think it could occur is because each Oxford House is democratically run and decides whether to let people come into the house or not. So the house has to vote 80% positive to let a person come in. So I figured, how can you send a person to a house versus not a house if you don't have control over that process? So we submitted grants for a number of years to National Institutes of Health, and I think over 7 years we weren't successful because the review group kept saying to us, do a randomized study, find out whether it works or not. So eventually we were getting to know Paul over the period of time doing some pilot work. I said to Paul, look, Paul, I know you want us to do a study. We were going to do a longitudinal study of people in Oxford houses, but the NIH wants us to do a randomized design, and so I don't think we're going to be able to get this NIH funding. Paul Malloy then said to me, he said, we'll make a randomized study occur. We can make it happen. And he worked with the Illinois group and the national group to actually allow us to do this randomized study. So again, that personal relationship of 7 years of getting to know them and building that trust, good communications, was critical from the research point of view, and the research point of view was really critical for the self-help organization to get data that they were interested in. The other piece that's interesting is a couple years ago, when I was talking to Paul, he mentioned to me that there was another group before I had approached him and had watched him on 60 Minutes a couple years prior to that, and had approached him and said, we'd like to do a randomized design of Oxford House. And Paul Malloy said, I don't know you folks. I'm not going to work with you, and I don't even know what randomized design means. So it's just interesting. Again, if you don't have that relationship and that trust built up, you know, you're not going to be able to do the types of research that sometimes you're required to by federal funding. We've also run into the issue of NIMBY, not in my backyard, many times. And I remember the first phone call I got. What happens is that communities try to exclude a variety of recovery homes, Oxford House is just being one example. They do it through a couple different methods. One is by saying you have to have a certain number of unrelated people. And if you have kind of more than 6, some towns, sometimes it's more than 5, they say that you can't live in that particular residential community. Well, one of the questions that was brought up when we got a phone call from a lawyer is, you know, what happens if you have a house that has kind of 6 or 7 or 8 or 9 or 10 people versus a house that has 5 or 4 or 3 or 2 people? Does it make a difference? And our sense was it probably would make a difference, because if you have a larger house, you have a better capability of paying the fair share and making it work economically. Generally, to stay in a house, it takes about $100 a person per week, so about $400 a month. So if you have 8 or 9 people in a house, you're going to be able to pay the bills better than if you have a smaller number. So we basically went into our data set, looked at house outcomes, and what we were able to find is that the larger houses of 6, 7, 8, or 9, or 10 actually had much better outcomes on a wide variety of measures. And we sent this to the lawyer. It was really probably the most interesting thing after doing this a couple times. One lawyer from one of the eastern states called me up in the morning and basically said, you know, we have this court case that's going on. It's been going on for a long time. You know, do you have any information that we can use to stop this community from trying to close down the Oxford House? And I said, yeah, you know, actually we have an article we published in the Journal of the Community Psych, and I had the PDF. And I sent it to them at around 11 o'clock in the morning. That afternoon, the lawyer called me up and basically said the case had been settled. Paul Malloy sent this note to me right after that. The dispute has been going on for 6 years. The town will pay attorney's fees, which are about $105,000, and a fine to the Department of Justice. The key to their decision appears to be your research showing that larger houses had better outcomes than smaller ones. Thanks. Once again, reason and logic prevailed. The reason I kind of mention that is there's a relationship that had been developing with Paul Malloy, different leadership within the Oxford House National Organization and the Illinois Oxford House Organization. And those relationships are both mutually helpful for both them in terms of using the research productively for their purposes, and for us to basically be able to have data that can ultimately make a difference as a community psychologist. Community coalitions, and again, this Oxford House is just one example, I think can revolutionize how we treat our most vulnerable citizens. The reason I got really excited when I saw this 60 Minutes piece, and by the way, I've never called anybody else that I've watched on 60 Minutes after watching it. This was a one-time thing. And you know, it was a funny thing. I really never even thought about it. It was kind of something I said, well, I've got to call Paul after I saw this thing. And this was just a small version of it. And I didn't question myself. And I had no idea what he would say. But I guess the reason I kind of bring it up is sometimes we have to just go with our gut feeling and just kind of say, you know, what do we think? What does that intuition tell us to do? And go with it. And I think sometimes it's just a much more powerful way of us behaving and acting and focusing our efforts in the world than some of the more cognitive processes. But the thing that caught my imagination when I saw the Oxford House, I thought to myself, there's millions of people who need affordable housing. And there's millions of people who don't have affordable housing, and people are substance abusers, of which about 30% are either on probation or parole. I mean, ex-offenders have the same problem. Ex-offenders come out of jail and prison, and if you ask them what they need, they say they need a place to stay, and they need a job. And what our society doesn't provide them is a job or a place to stay, or a support system that helps them in their recovery if they're dealing with substance abuse. So I got excited about this, and I thought to myself, Oxford House is one creative approach, and it deals with these types of issues synergistically, and possibly this model could be used for other things. And I might add that kind of right now, there's a group from different parts of the country that are trying to use this Oxford House democratic self-help approach for homelessness and also for domestic violence. And that's really exciting to kind of see this. So, in summarizing the third principle of social change, community coalitions can be mobilized to transform many of the most serious problems that affect our society. They can change power structures that perpetuate institutional ways of treating people. These bottom-up social change movements can create community-based programs that allow people to be reintegrated into society. The fourth principle of social change involves second order. It takes time. Progress can be gradual and uneven. There will be setbacks along the way. Patience and a long-term commitment. That's the fourth principle. It's what I at least have encountered again and again in the different projects I've worked on. It seems to be a critical aspect of the work that I've done in social change, and at least what I've seen from others. Patience and persistence, essential in opposing powerful vested interests intent on maintaining the status quo and amassing coalitions to confront institutional abuses of power. That willingness to stay with it and have setbacks and not be successful, but to just stay with the cause. And again, I'd like to give another case example of just the importance of this case committed to a cause, how a small win can help sustain and mobilize citizen groups to continue to pursue even larger objectives. It's been something that I've experienced, and I've seen it experienced by community coalitions. So in the pursuit of social justice, small wins cannot be overemphasized. So let's just think about what that might look like. And let me give an example of a controversial illness that people know as chronic fatigue syndrome. Many health professionals continue to doubt the scientific validity of this illness. So here's some reasons or some issues that patients experience. 95% of people with this illness seek medical treatment, report feelings of estrangement. 66% of patients with this illness say their illness was made worse by their doctor's care. This is pretty outrageous. What are some of the multiple problems confronting patients with CFS? First, it's called a derogatory yuppie flu illness that contributed to negative attributes that healthcare providers have towards this syndrome. The name given by the CDC to the illness trivialized and stigmatized the term. The CDC's case definition of CFS did not specify cardinal symptoms, leading to unreliability problems, and tests used to diagnose patients were biased toward finding psychiatric problems. I'll give you a quick example, but I could give hundreds. Basically, people say, well, the movement, the activity of patients with CFS and patients who are healthy are the same. You don't see any difference in terms of if you put pedometers or actigraphy on them. But if you kind of look at this particular case example here, here's a control person, and you can see they have movement. This is higher movement, and this is lower movement. Here's sleep, and here's higher movement. These are 2 days of activity. Here's a person with CFS, and you can see there's busted activities. There's no diurnal patterns, and the sleep at night doesn't work. This person's not resting. The total amount of activity is the same in these two slides. So if you basically use these, and this is what happened, people were using data without looking at the patterns of the data and incorrectly concluding that patients had a perception of a problem. But this is clear evidence that they do have a problem. Let's focus on prevalence. The CDC in the late 1980s, early 1990s suggested that only 20,000 people had this illness. It was characterized, as I mentioned, as a yuppie flu. But if medical personnel believe that CFS is a relatively rare yuppie flu disorder, physicians might minimize or misinterpret the physical complaints of patients with CFS. This could lead to mistrust and lack of communication as reported by patients. Well, the CDC's case ascertainment methods were flawed. Physicians identified patients who presented with unexplained fatigue-related symptoms and referred those patients for medical examination. But this methodology excluded those with low income who did not have access to medical settings because many physicians doubted the existence of CFS and they might not have made referrals to CFS prevalence studies. Our intuition felt that there was something wrong. We had a gut feeling, and we reached out to patients, professionals, organizations to become allies. And over time, we built a network of collaborators, including patients, graduate students, the CEO of the largest patient organization, epidemiologists, physicians, psychiatrists, biostatisticians, survey researchers. It took us 10 years to work on this one issue of prevalence. That's what I mean by a long-term commitment to an area. So let me give a little bit of that issue. We submitted an NIH grant, and we were told basically, well, the CDC has already found there's only 20,000 people with the illness. So if you do a community-based study and randomly select 28,000 people, you won't find anyone. Well, we collected pilot data, and we found that we actually found some people in a small pilot study funded by the patient organization that wanted to get some good data. Then we went back to the NIH, and we said, well, okay, we now have pilot data. And they said, well, we're not interested in CFS prevalence because the CDC has already told us what it is. And they said, why don't you study something else like multiple chemical sensitivities? I said, we're not experts in that. They said, that's okay, we're not interested. Well, our intuition told us that this needed to be done. So we kept submitting and resubmitting grants. And I think, as some of you know, I can be a little persistent. We eventually did get the grant, fortunately. We phoned a random sample of 28,000 people. Those who self-reported having symptoms, we had a medical and psychiatric workup. The prior estimates suggested 20,000 people. Our estimates were that there were 800,000 to 1 million. Of those identified with CFS in our evaluations, 90% had never been diagnosed. Why? Because they went to community clinics who didn't have the appropriate medical expertise to diagnose them. Ethnic minorities had the highest CFS rates. So much for the upper flu disease. As you can see, Latinos actually had a higher rate, 726 per 100,000 to white people, almost twice the rates. Well, the study got national attention. Chronic fatigue no longer seen as yuppie flu in the science section of the New York Times, and Chicago Defender as 2 examples. Because of the wide dissemination of this prevalence research, it gave me a chance to get into the policy domain immediately. I was appointed chairperson of the research subcommittee of the CFS Advisory Committee, which makes recommendations regarding CFS to the U.S. Secretary of Health and Human Resources. It's easy to become overwhelmed when confronting complex problems or power holders. By focusing on one small issue at a time, we're able to put into policy at the CFS Advisory Committee. For the next 10 years, we were able to work on a number of issues in that policy arena, such as the inappropriate name given this illness, an expanded case definition, and CDC leadership problems. The 10 years of working on this prevalence study successfully did challenge the myth that CFS was a yuppie flu disease. Small wins during this time led to opportunities to work as a federal official on other issues. Efforts, for example, are underway right now to rename CFS myalgic encephalomyelitis. I might add, this was the name that the illness was once called before the CDC in 1988 renamed it chronic fatigue syndrome. All right, the 5th principle of social change, measuring your success. Evaluations can help redefine the essence of each principle of social change. Program evaluations can reveal weaknesses, identify where the weaknesses stem from, and help focus efforts on critical stages of systemic change. Last principle of social change. The effects of social action are often not immediate or easily identifiable. While the dynamic nature of social activism campaigns may make evaluation challenging, measuring progress is vital and lies at the heart of each community's strategy. We can certainly use self-report data, archival policy, or actual behaviors. So, where would a talk like this end without me talking about pooper scoop? Unfortunately, this is probably what I'm best known for my entire career. So let's go through the story of how this all happened. After inviting the Chicago aldermen from my area to my community psych class as a young assistant professor, I said to myself, I would tackle whatever he mentioned as the most pressing issue. When I asked him that question publicly, he said, uncollected dog feces. Literally, my mouth fell open in disbelief. With trepidation, I counted all the fresh dog feces within an 8x5 block area. And of course, we had to define whether it had color and texture so we can reliably make sure whether it was old or new. We really got this down to a science. The fact that there were 11,470 droppings within this area made me realize that dog litter was a serious and prevalent problem at the time. Well, we had to get our hands dirty. Imagine what it was like recruiting graduate students who were trying to study clinical psychology, coming to DePaul and finding they were going to work with me on dog shit. Anyway. True story. Well, we counted the number of dogs who defecated, the number of dog defecations picked up, and we picked up and weighed all the dog defecations in the morning. And I got infected with fleas as well. Talking about getting your hands dirty, whatever. During the baseline phase, we found few dog owners were observed to pick up after their dogs. By the way, they kind of mentioned that my dad was a comedian. Some people say I did this study so my father would have more ammunition on the stage. Can you imagine him getting up in the Catskills and saying, my son is a psychologist and what he's doing is collecting dog shit? He actually said that. Well, over 19 pounds of dog defecations were deposited in a target block that we studied intensely as good community psychologists. We put up anti-litter signs as a way of trying to see if that would work, and the only thing that happened was our anti-litter signs were torn down. Well, we then walked up to the dog owners. We showed them how they could pick up dog feces with a plastic bag, gave a demonstration, and we were actually very happy to see that 82% of dog owners picked up after their dogs. And as you can see, defecations here were this amount, and pickups were this amount, and over time, you can see that most people were actually picking up after their dog. This is called reversal design behavioral. So I testified at a city council hearing, and the report of the Chicago Daily News said, in what surely must be the most bizarre academic study in the nation, just what I needed. I wasn't tenured at this point. They subsequently calculated from our work that 382,000 pounds of dog excrement were deposited on city streets, and the report has said it generated great readership interest. This was the study. The editorial in the Sun-Times, we're not sure what contribution the study makes to the discipline of psychology, but if it persuades the city council to pass a strong ordinance to discipline dog owners, it will have been more than worth the effort. The city could always fund the professor's research project. The pursuit of knowledge aside, it did manage to clean up one neighborhood. And there were cartoons in the Chicago Daily News about solutions. I got tons of fan mail. Matter of fact, when this thing got going, anybody that sees anything with, bird droppings or any type of droppings, they send it to me and they want me to get involved, and I don't understand why. So this one alderman did approach me, and I did work with the community organization, a 9-month collaborative to reduce dog litter in their area, and we actually had some good success with the same strategies in the entire area and the target block. We were able to demonstrate you could really reduce dog litter by getting people to be responsible. Well, as I mentioned, I testified at City Hall to support an ordinance. It would require dog owners to have their possession of pooper, scooper, and walking dogs. This ordinance was passed by the City Council, and Chicago is one of the first cities in the country to pass a pooper, scooper ordinance. This was the letter from the alderman who came to who we initially were working with on this. In the past, this problem has been scoffed at and not taken seriously. Your comments regarding the dog defecation problem altered that perception greatly. For the first time, the legislators were willing to seriously consider enacting legislation to help alleviate the dog litter problem. And Chicago's ordinance did become a model for other ones around the country. So the final principle of social change is consider the tangible short and long-term results of our activities. Using evaluation techniques, we can determine whether or not a particular intervention or social change strategy has achieved its goals. Few initiatives are successful without some type of documentation to support our efforts. A funny story, just to kind of end this thing about the dog litter. In about a couple of years after doing research with Ed Zola, a good buddy, and I was kind of, again, an assistant professor at the American Psychological Association convention. my mentor, Emery Cowan, walked into a very large room, and I was on the other side of the room, he was on the other side of the room. There were about 100 people there. These were all people that I was trying to kind of get to know, these are people that be influential in my career, and many people I've read their chapters and books over the years. And Emery, in his own kind of way, kind of looked at me, said, "Oh, there's the dog shit man." I realized at that point I had to stop doing research in that area. In any event, the 5 principles of social change that we've talked about: determining the nature of the change desired. Is it a cosmetic short-term fix, or does it address the root of the problem? Identify the power holders. Create coalitions, identifying and working with others who share your goals. Learning patience and persistence. Small wins are crucial to attaining long-term goals. Constantly evaluate and refine strategies and tactics to find the most effective means of bringing about change. In this presentation, I've really gone through 5 very disparate areas, and I'm sure that I could have used many principles just as well to illustrate the types of work that is going on by my colleagues in the audience. But I worked on reducing youth death through encouraging use of appropriate car restraints, reducing youth access to tobacco as well as decreasing youth tobacco use, promoting the expansion of safe housing for people with addictions, challenging inappropriate myths and stigma regarding MECFS, and promoting laws to reduce uncollected dog litter. Lessons learned: each principle of social change represents part of the social change journey, but they are subtly interrelated. When used tactfully in concert, they can create an unstoppable force in any movement. I'm going to sort of show this little video that we just recently created. I want to thank all my collaborators and staff and the volunteers. This is a little piece that